Right, well, good afternoon and good evening, everyone, wherever you're joining from. Thank you very much for your continued interest in this program. Hopefully it's proving useful to you. So you've had quite a lot of external speakers over the last few weeks, which is good. Next week, it'll be back to an external speaker, Dr. Hamid Kazarunai, who's Deputy Chief Medical Officer of Diagnexia. Diagnexia is very graciously supporting this program of teaching, and he'll be talking about cervical and adnexal pathology. So, as usual, not to do myself down, but I'm the kind of like interval filler between the external speakers, but I've got a whole set of hemopath cases that have actually accumulated over the last several weeks since I've done hemopath teaching. A variety of cases showing a lot of interesting pathology, so not as symptomatic. The other thing to say is that going forward, we have now the program in place to the end of this academic year, so to the end of July 2026. So please share the link freely with your colleagues. The more we can build this community, the better. Right, so without further ado, I will start with the first case. Let me share my screen. So if anyone, if anything, if there's any problems, can someone please put their hand up and shout out so that I don't leave people behind? Feel free to ask questions at any time. Hopefully these sessions with me are interactive. So I've got a whole variety of hemopath cases that have all come to our very busy hemopath service. It's also quite difficult for me to manage my multiple screens, so please bear with me with that. So I think the first one I'll start with is actually one that we have looked at, those of you who've got exceptionally good memories, before, but it kind of sets the scene for the next case, the next new case that we will look at. So I'll just get up the clinical details for this case. Clinical context is always everything. So this is a 59-year-old man, and he's come in with extensive bone lesions and a raised leukocyte dehydrogenase, or LDH. His LDH is 1,968. His blood count, he's got cytopenias, so particularly low hemoglobin and low platelets. His hemoglobin is 83, so it should be about 130 odd. And his platelets are 46. Neutrophils and white cells are actually relatively normal. So this is his marrow. Let's try to auto-white it. That didn't really work very well, did it? Let's just auto-white it on a blank piece of the screen. So this is his marrow. So a reasonable core of bone. I've only got the H&E for this case. And within it, you can see transcript. There's quite a lot of fibrosis. That's indicated as well by these ectatic vessels that have been pulled out. And within the fibrosis, there are these atypical cells, some of which are vacuolated. There's also within the marrow focal necrosis. If I find the necrosis, so So it's focal hemorrhagic necrosis, and this isn't post-chemotherapy. You often see necrosis post-chemotherapy in marrows, but this is not post-chemotherapy. So we've got a fibrotic marrow with atypical cells in it, high fibrosis, and without too much further ado, before I go on to the next case, which is similar, any ideas what this may be from the audience? We'll try and get a bit of participation going, so I don't have to do all the talking, sorry. Anyone want to say what they think this might be? Or any requests for any further information? So here we've got these atypical cells in a sinusoid. This is any replies in the chat from anyone? No. Okay, well, I'll tell you what they were positive for by immuno. So they're positive for broad spectrum cytokeratins, A1 stroke A3, positive for CK7 and CK20, particularly CK20 was stronger. There was also some patchy staining for CDX2, which is a gastrointestinal marker. And they were negative for a range of other markers. So negative for SATB2, Napsin A, TTF1, GATA3, PAX8, and prostatic acid phosphatase. So this was considered to be a colonic primary tumor, which is fairly poorly differentiated, but you can see it's vacuolated, so that would be consistent with an adenocarcinoma. We don't often see metastatic disease. That's you can see that's a really good example of how it's got into the marrow by going into the lymphatics and blood vessels, and you can see it here within a blood vessel, and then also in the surrounding marrow. Now, I've said in the past that the two things which cause fibrosis in the marrow are myelofibrosis and metastatic carcinoma. We'll see an example today of another thing which can cause fibrosis, which I must say I've not seen before. So that'll be an interesting thing to see along the way as well. So that's the first case. And we have a similar case, which I will go to. Let me find it. Okay, there's a 65-year-old woman who presented with CT and MRI findings suggesting an enhancing soft tissue deposits within the pelvis, proximal femur, spine, sternum, clavicle. Could this be a hematological malignancy? So I think that degree of spread of soft tissue masses, if it was hematological, could only really be a myeloma. You wouldn't really find a lymphoma within the proximal femur, spine, sternum, and clavicle. So clinically, it's either a myeloma or metastatic carcinoma. And this is the entirety of the biopsy. Not big. So mostly fibrous periosteal tissue. But you could wonder whether this is actually even a marrow. And there is a tiny bit of marrow there, which is important. Then the majority of it is periosteum, some skeletal muscle, some periosteal fat, and just this very small piece of marrow. So there's clearly something in the periosteum, which is this. So we've got these deposits of tumor within the periosteum there and there, and they are glandular. So it's adenocarcinoma. You can see it forming glands. For instance, here you can see glandular structure there, and you can see a glandular structure. If I go back to it, let's find it. There's nice glandular structure there. Maybe not so much there, but certainly there. And the cells are relatively poorly differentiated. Difficult to say what it is, but it's an adenocarcinoma with extensive spread. And the key thing is whether there's anything like this within the marrow. So certainly we know from the history that it's metastatic, and now from the histology that it's metastatic at least to the periosteum. But the question is whether it's metastatic to the marrow, the bone marrow itself as well. And I think that it is. You've got another area like this. So this is metastatic both to the periosteum, but also within the marrow as well. So in fact, in terms of classification, it doesn't really matter where it's metastatic to. If it's metastatic at all, that's really all that matters. But it is actually not just in the periosteum, but it's in the marrow as well. So we do have a whole load of immunos for this, which my colleagues have reported. So I will go through them, not all of them, but at least some. So if we look at the broad spectrum cytokeratin A1/A3, which is here, and this nicely shows the fact that you've got positivity within the periosteal areas and also moving across into the marrow. Actually, quite a lot of tissue within the marrow. And it's not just that it's fallen off the periosteum because it's actually got marrow around it. So there is disease within. So that's A1/A3. I'm sure you're all much more expert than me on the differential diagnosis using CK7 and 20 for tumour of unknown origin, because I only do Haemopath. But this is the CK20, which is nicely positive. And this is the CK7, which, if I can find it, yeah, is nicely negative. Okay. And the control was positive. There's the control there. Yeah. So CK7 negative, CK20 positive, and it was also positive for CDX2, it's a nuclear marker. Nice positivity in the marrow for CDX2. So this is metastatic colorectal adenocarcinoma. A further information came to light during workup of this case. The patient had presented with some bowel symptoms and a positive FIT test, so fecal immunotest. They had a colonoscopy in August this year, and biopsies were taken from a suspicious looking rectal lesion but surprisingly showed no evidence of malignancy. So I think it's really unusual. This poor patient, they've obviously got bowel symptoms. They've had positive bleeding from their from a lesion, despite colonoscopy. Um, they didn't see. They saw a suspicious lesion, but they didn't manage to get evidence of malignancy, and it's really only been demonstrated by the demonstration of widespread metastatic disease. So I think that's quite unusual to have. They couldn't find a lesion, confidently find a malignant lesion on colonoscopy, and yet you've got this widespread metastatic disease. So spine, sternum, clavicle, bone marrow, pelvis. It's a very, very extensive disease. The next one, that's not the most interesting one, and maybe not that one, but maybe, yeah, this is another interesting. So changing gear slightly. Actually, let's just see. Yeah, right. So we've had two cases with some fibrosis. We talked about fibrosis and query malignancy. And now I'd like to show you this case. So, is everyone still with me? I'm just checking. It's difficult to, a bit like being on the radio, speaking to a bit of a vacuum. Can I have a thumbs up or a thumbs down as appropriate from anyone, just to indicate that I'm still on track here? I don't know how people can do that. Anyone able to say that they're still there? Great. We've got a thumbs up there. Thank you. Right. So this patient, let me get the details up for this patient. Right, 57-year-old woman. She's had a long clinical history, actually. So I'll just go through this long clinical history. She had a solitary plasmacytoma in 2019, and she was treated with radiotherapy and vertebroplasty. And then she progressed to a myeloma in June 2021, which was treated, multiple rounds of treatment. It has recurred. She's now come in for trial treatment, and this is a marrow assessment at baseline prior to the trial. Her hemoglobin is 109, platelets 316, so that's normal. Neutrophils 3.3, that's normal. So she's mildly anemic. She's got free kappa light chains and a paraprotein of 57 grams per litre. And this is her marrow. Excuse me. So her marrow is clearly abnormal. You have a large deposit there. Thanks, Mungai. Thank you. Thank you. When my wife and I were in Aga Khan, my wife did an audit of all the cases coming from all over Kenya to the Aga Khan, different types of carcinoma. So I recognize that many came from Meru. So thank you for the excellent work you're doing up in Meru. So we've got these two big areas of infiltration. And this is probably something you see quite a lot of, I guess. I don't know, maybe we could just have a bit of a poll. How many people commonly see myeloma? Is myeloma a common disease in your area or not? Or do you not see a lot of myeloma? I'll just stop for a moment there to see what people say. So in the chat, who sees a lot of myeloma or not? So we see a lot of myeloma here because we are a renal transplant hospital. So got a big renal service. So I think we see a disproportionately high amount of myeloma, but I don't know how common it is in your territories. Or is it not biopsied, except by fine needle aspirate or cytology? A lot in central Kenya. Okay, thanks. So this case, okay, frequently seen in relatively frequent in Bosnia. Okay, thank you. So myeloma, I always think that the diagnosis of myeloma is a simple diagnosis. Just do some immunos for kappa and lambda light chains, and that's it. There's not much to myeloma. I have to give a talk about myeloma. Well, I've chosen to give a talk about myeloma to the Association of Clinical Pathologists, and I always wonder what to say about myeloma, but I always find there's more to say about it than I think. So here we have obviously an abnormal infiltrate with atypical. That was no good. I don't want to try and keep it nicely color balanced. So we've got lots of atypical plasma cells here with eccentric nuclei, a huge patch of cells. I mean, obviously we will do light chains and I'll show you those, but this has got to be myeloma. And in fact, it's got to be multiple myeloma because it's going to account for more than 60% of the cells present within the marrow. It can't really be anything else. The interesting thing about this case is the background. And here is the background. And you can see that it looks fibrotic. Okay, and I don't think I can't remember seeing this before, certainly not to this degree. And if we move to the reticulum, this is the reticulum. So this is increased grade 3 in the WHO classification. If I just go through the classification, there's two main classifications you can use for reticulin and fibrosis staining. There is the Bauermeister scale. Let me just see if I can bring this up on the internet and share it quickly. Okay, so let me just stop this share. This is something that people find, I always find this difficult. There, you should see that now. Just got a thumbs up. You can see this paper. Quite a good paper, actually. Thumbs up from anyone? It's showing adequately, is it? No? Okay, I'll assume people are with me still. Okay, still sharing the slide. Now, can you, let me see. Yeah, can you see it now? Great. Okay. So this paper here, which I've just discovered right now, is a comparative study of the modified bowel master scale and the WHO scale. It's actually a 2016 WHO scale, but it's not really changed in the present iteration of the WHO. So there are two main grading systems for reticulin fibrosis, and it's important, I've said this before, but it's important when you do a reticulin stain that you also counterstain it with a trichrome, because collagen will not stain differently otherwise with the reticulin stain, which is just a silver stain. So to see the collagen, which is this kind of like, which is the purple background, go back to the slide. So this purple tinge to the background there, for instance, in particular, um, that you need a trichrome to see. So we have these reticulin fibers plus the collagen background. You can see the fibers are wavy, and there's a sense of slight purple staining in the background to these fibers compared to these, which are just black. And these have got a slight purple staining in. So if we go back to the new share and share that paper, we've got the modified bowel master scale, which is down here and up here, which goes to grade 4. And we've got the WHO scale, which starts at 0 and goes to 3. So I've always found that the bowel master scale is actually it's more discrete between each point. So grade 0 is no reticulin fibers. Grade 1 is occasional fine fibers. 2 is a network of fine fibers, but no coarse fibers. 3 is a diffuse network with scattered coarse fibers. And 4 is additional collagen fibrosis. Whereas if you look at the difference between grade 2 and grade 3 in the WHO scale, grade 2 is diffuse and dense increase in reticulin, intersections, focal bundles of thick fibers. And then grade 3 is diffuse and dense increase in reticulin with extensive intersections. It's the same as grade 2. And coarse fibers with collagen. But this also says with collagen. So I've never really been able to work out exactly what the difference is between grade 2 and grade 3. I think grade 3 is just worse. Example of grade 2. The way I do it is I look in my mind and say, what would it be in the bowel master scale? And then take 1 off the number. So if it's grade 0 in the bowel master scale, that would still remain 0 in this one. If it's grade 1 in the bowel master scale, that would be grade 0 in the WHO scale. If it's grade 2 in the bowel master scale, I call it grade 1 in the WHO scale. If it's 3, I call it grade 2. And if it's grade 4 in the bowel master, I call it grade 3. And I think that that is the most objective way of doing it as far as I can see. In Barbara Bain's book on bone marrow pathology, it does say that the bowel master scale is better, but we are, of course, obliged to use the WHO scale now. So that's a bit of a roundabout way of saying this is how I approach reticulin scoring. And we'll see another case as we go along that actually looking at the reticulin scoring is important for classification, certainly of myelofibrosis and certainly for post polycythemia vera and post-essential thrombocythemia myelofibrosis is important what the reticulin grade is. So back to where we were, we've got, I'm not quite sure. Yeah, so we've got a nice example of, this is grade 4 in the Baumeister scale or grade 3 in the WHO scale. And the reason why that is interesting is, if I can find it here, is this. So this is a case of myeloma. And I've spent a lot of time on this case, but it just shows you always find something new. And this is all, I mean, I knew obviously about the reticulin grading, but to be honest, I didn't know about the relevance of fibrosis in myeloma. Just goes to show you learn something new every day. But if you only learn one new thing every day, you still learn quite a lot. So this is the CD138. So these are obviously all plasma cells. And it also shows, just to convince you that they are neoplastic, I don't think anyone should need convincing of that. But this is the lambda. There are occasional residual cells. And this is the kappa. Okay, where's it gone? Yeah. So I don't think there's any doubt about light chain restriction in this case. And there is also marrow fibrosis. So this is a really interesting case because if we look at this paper, oh, I didn't stop the share, did I? Thank you. Yes, I didn't stop the share. Someone has told me in the chat. Right, I will go back to the slides and change the share. So this is the CD138. And you can see this confirms very prominent plasma cell infiltrate. And I said I'd looked at the kappa and lambda light chains. So this is the kappa. And you can see there's less staining than I would have liked actually, but there's definite good staining there. Nice cytoplasmic staining. And the lambda shows no staining, a very occasional residual cell. So it is restricted. We also did a MUM1, a nuclear plasma cell marker. Which always, I think, gives a better estimate. And there you can see very extensive plasma cell infiltration. So to go back to this paper, there's a paper from Japan in 2022, and they looked at 91 multiple myeloma patients and looked at the impact of fibrosis. 37% had greater than grade 1 marrow fibrosis. This is obviously up to grade 3. I'd have to look at the full paper to see whether they used the WHO or the Baumeister scale. But anyway, at least grade 1 to 2. So it had no influence on any paraprotein levels, the percentage of plasma cells, but it was significantly associated. So a p value of 0.006, that's pretty significant. Was associated with the incidence of extramedullary disease. Interestingly, this woman, we go back to her clinical history. her clinical history was that she started off in 2019 with a solitary plasmacytoma, okay, which then developed into a myeloma. So that's interesting that in this paper, um, it's associated with extramedullary disease. So something new that I've learnt, and hopefully you've learnt. And it fits in with the clinical history, in fact, in that woman as well. Okay, this is another interesting case. I mean, quite often I say to people, there's no such thing as interesting cases because all cases are interesting. No, it's not what I wanted to share. I wanted to share something else. Okay, right. Back to another case. So this is a 75-year-old man who has had a history of Philadelphia positive B cell acute lymphoblastic leukemia. There's a bit of a discussion point as to how you diagnose B-ALL, and this is his marrow. So his hemoglobin is 98, white cells 5.2, platelets 82. The aspirate was insufficient because it was too dilute. I don't think he's got an increase in reticulin. And this is his marrow. And you can see, even at lower power, that there isn't really any normal representation of hematopoiesis in it. It looks like these are all mostly blasts. They all look the same. There's no real maturation. Presumably you can all see that. Yeah. Okay. So medium sized and occasionally small blasts, irregular nuclei, a bit of eosinophilia as well, actually, which is interesting. And it's almost all blasts through his entire marrow. So this is recurrent disease. And the question is what's the lineage? Okay, so we know, we've been told that he's got B acute lymphoblastic leukemia. So this is, I'll just go through the immunos one by one. This is CD10, which is a marker of lymphoblastic differentiation. So it's strongly positive for CD10. CD19, B cell marker, often not positive in a marrow, actually. But in this case, there is nice CD19 positivity. CD20 is negative. And when you see a negative marrow as negative as that, you've really got to check the control. Now these patients are extensively treated with rituximab, certainly in the UK and in most places. So that accounts for its CD20 negativity. It's also negative. It's positive for CD79A, which is obviously not targeted by rituximab. It's positive for TDT, which is a specific marker of lymphoblastic differentiation and a nuclear marker. It's positive for PAX5, which is a nuclear marker of lymphoblastic differentiation, if I can find the thing. Where is it? Yep, nicely positive. It's positive for CD34, which is an immature blast cell marker. So far, all good, no problems. Next, we come to myeloperoxidase. This is myeloperoxidase. Can find it. And there we have it. Right. So we've got positivity for a range of B cell markers. So CD19, CD79A, PAX5, two lymphoblastic markers, CD10 and TDT. Positivity for two myeloid markers. CD34 is generally a myeloid marker, and myeloperoxidase. So what are people's views as to what the lineage of this is? What do people think? Can anyone? Yeah, it's hard for me to navigate everything. Okay, so we've got um, Matthew or Matthews. Matthews? Yeah. So MPAL B myeloid. Very good. Anyone else? How many other people think it's an MPAL B myeloid? So if we go to, if I just share a couple of okay, so this is recent paper from 2020, 2025 actually. So acute leukemia of ambiguous lineage, diagnosis and evaluation by flow cytometry, and the MPAL has got to have more than 20% blasts. They've got to have more than one lineage, and these are the different variations you can have, and the immunos for those. So for myeloid, MPO intensity exceeds 50% of the mature neutrophil level. Well, it's well over 50% here. The thing about the MPO is that in this case, the flow cytometry for the MPO was only 5% of the cells. So I have found somewhere else in the past, someone did they looked at the difference between flow cytometry versus immunohistochemistry. And what they found was that there wasn't always a great concordance. So in order to make a confident diagnosis of an MPAL myeloid, sorry, B myeloid, as Madakwa has suggested, and I think I would have suggested in this case, but really to be certain about it, the MPO has got to be positive on the flow cytometry and not just by the immuno. And we've seen in our lab quite a lot of discrepancy between the MPO staining by immunohistochemistry, which is really strong here, and would definitely go with an MPAL B myeloid lineage or classification. versus a low flow cytometry, which would go with a BALL. So in this case, after MDT discussion, it was decided to call this a BALL, and this myeloperoxidase positivity was disregarded in terms of lineage because it was only represented in the immuno. So it's important really to base it as far as possible on the flow cytometry. That's the only point that I wanted to make about this case. It's a bit of a moot point, actually. But I think that it's looking at the WHO classification and the criteria, it's best to base it on the flow cytometry rather than on the immunohistochemistry. Of course, the flow cytometry represents the external expression of myeloperoxidase on the cells, whereas the immunohistochemistry represents the cytoplasmic MPO, so it might not be expressed as much. But it's a point to take note of. You may decide in your practice that in fact you're quite happy to accept the MPO by immunohistochemistry, but in general we only accept it if it's replicated in the flow cytometry. That was the point of that case. See what else we've got. Okay, right. I've got 3 short cases of amyloid I can show you. Unfortunately, I can't polarize them. We don't see a lot of amyloid. We often look for it, and we look for it in pretty much all our cases of myeloma. We rarely see it. We used to do both a Congo red and a Sirius red histochemical stain for amyloid. Now we have discovered that the Congo red is better. Previously, the Sirius reds were better, but we've got good Congo red staining now. So the first patient was born in 1979. So 45-year-old, he's got low-level clonal plasma cells, only 1 to 2% of the nucleated cells. And he's got known AL amyloidosis with cardiac involvement. This is his marrow. So this just shows the differential presentation of amyloid in 3 short cases. So there's number 1. So looking through this marrow, there's not a huge amount to see, really. Doesn't appear to be infiltrated. The cellularity seems to be reasonably good through it. Contrast the previous case, very difficult to see plasma cells. We can go to the immuno to see how many there are. So hardly any. I've got an immuno, so I'll show you mum 1. Sometimes. I think you can appreciate there's not many. So you're struggling to see them. 1, 2, 3, 4, 5, 6. Hardly any. Really low percentage of plasma cells. I think once it gets down to this level, demonstrating light chain restriction is almost impossible by immunohistochemistry. I'm not sure if I can convince you of it. This is the CD. Sorry, this is the kappa. Well, there's occasional cells like this one, and this is the lambda. I think there is in fact lambda skewing. There's more lambda than kappa, and it should normally be the other way around. So we have got more kappa than lambda, so it's skewed towards lambda. Can we see any amyloid, which is usually around blood vessels, on the H&E? Well, I have looked at this case in advance, so it makes it a little easier for me. But even so, it's pretty difficult. So there's a blood vessel there. Can't see any amyloid there. Right. I don't think I can. There's a little blood vessel there. Dead center now. I can't really see any amyloid there. Right. Well, we did the Congo red. I'm sorry I can't polarize it on this microscope. You have to take my word for it being positive or negative. But just luckily, this red staining here is actually positive. So we've got a tiny deposit of amyloid within this biopsy. And that really is one of the most subtle I've seen. So that's the first case of amyloid. Next, I'll show another case of amyloid. This is a case that my colleague has given me. It's a patient who is diabetic and they inject insulin. And in fact, this is not a bone marrow biopsy, but is a skin biopsy. So there's a piece of skin. We'll ignore that one. It's a normal piece of skin. They've got a mass. They've developed a mass. Whoops. And this is the mass lesion. And they have all this pink material. So this is an insulinoma or an insulin deposit. And it's aggregated because they've not been swapping around their ejection sites, and it's aggregated into areas of amyloid. So there's localized deposits of amyloid within the soft tissues due to insulin injections, which I must admit I've never seen before. And here we have it. Large deposits of amyloid due to insulin deposits. And you can see amorphous eosinophilic material. Now, if we stain that with Congo red, just to, again, I can't polarize it, but I can show you it's red. This is it. It's not very strong, to be honest. It's a bit weak, a bit wishy-washy. Not our laboratory, coming from a different laboratory. So you've got to get your Congo red staining good. And it's not as bright as ours, but there is positivity for amyloid. And the third case is an autopsy case that I did a couple of weeks ago now. And the patient had an ERCP for gallbladder disease. This caused hepatic abscesses, unfortunately, with septicemia. And then obviously as a PM, they died. So there was hepatic necrosis. There was quite a lot of quite widespread hemorrhagic hepatic necrosis. The gallbladder was inflamed and thick-walled. There was evidence of some kind of multi-organ failure, ARDS in the lungs as well, as you'd expect with septicemia. And I haven't got the H&E, but I've just brought along the Congo red. This is the wall of the gallbladder. And you can see within the wall of the gallbladder, it's quite beautiful Congo red positivity. And this is also birefringently positive. But around all the walls of the blood vessels in the gallbladder, there's this deposits. These are all Congo red positive. So this is amyloid. There was also similar features around the blood vessels in the liver and also within the lungs. So this patient's got systemic amyloidosis, which was not suspected previously. I'm not certain whether it's contributed to death or not. So I don't know whether having such extensive amyloid around small blood vessels, both within the gallbladder and the liver in particular, has caused an abnormal reaction to the ERCP, endoscopic retrograde pancreas or cholangiopancreatography. I don't know whether it's caused an abnormal reaction to it because these vessels might have spasmed a bit, I don't know, through the ERCP, or whether it's just an incidental finding. I've put it down in the cause of death in part two, which are things which have um, contributed but not directly caused death. I think it has probably contributed in some way because it's very extensive and it is in the area of abnormality. I don't think it's directly caused it. I don't know what anyone else's view would be, or whether it's just an incidental finding that's not important. Who would, of the people on the line, who would include this as part of the cause of death in someone who's died from septicemia and hepatic abscesses post ERCP? And would anyone else include this as part of the cause of death? No, not directly. I'm just interested. Anyone? So we've had a few people reply so far. Anyone going to put this, stick their neck out and include this as the cause of death? Help me out. No. Okay, I'm on my own on this one. Okay. Um, I'll have to stop there. So we're up to the hour. I have an MDT to go to. Thank you very much for your attention. Ava, I presume you're still on the line?
Yes.
Okay. So Ava, would you be able to send me the attendance numbers when I think you get that when it closes, don't you?
Yes, I do.
Yeah. Yeah. Um,
Okay.
and to the rest of the audience, I think that those I hope you found them interesting. To be honest, out of all the cases I've shown you over the last few months, yeah, yeah, thank you very much for your thanks there. I think they were the most interesting cases. Um, it just shows you even things which are relatively straightforward, like diagnosing acute leukemia, diagnosing myeloma. Um, there's still a lot of interest all the way around. Uh, And can anyone just tell me which countries they're in before we go? Because it's always interesting for me to see where I'm speaking to. USA. Oh, great. We're really traveling far and wide now. I think if we get anyone in Australasia, we've virtually circled the world with this talk. Yeah, Madagascar. Great. So please share this with everyone. Um, I'm only doing this for everyone's pleasure. It's Taiwan. I think we have circled the world. Yeah. India. Great. Tell all your colleagues. We want to see, we've put it to a webinar platform and get as many people in this as possible. It's not that I'm megalomaniac. I'm not at all. Sometimes I wish I'd be quite happy just going out, riding my bike and running on the hills, but we want to make this, we would like to make this with Diagnexia's support, the premier teaching platform, largely due to all the excellent external speakers we've got. So Botswana, Kenya. That's a really great list of countries there. Thank you very much. And next week we Dr. Hamid Kazaruna, who I think is will be presenting from Canada on gynae pathology. I don't know, Ava, if maybe you'd be able to share with the group um, the kind of like timetable going forward. We don't need to do that right now, but on one of our next posts, because we have the timetable prepared for the whole year ahead. Would that be possible? I can work with you on getting that ready.
Yep, definitely. I can send out an email to all of them as
Yeah,
well. Yeah, you
yeah,
bet.
yeah. Um, and we'll also be exploring soon the opportunity of sharing slides in advance. Can't promise anything just yet, but I think it's going to be a possibility for speakers to be able to share their slides in advance of these meetings. So that would also enhance the opportunities for everyone. Okay, thank you very much wherever you are in the world. And I have to say good morning, good evening, and good night over such a wide territory, and look forward to having lots of you online next week. Please share with all your colleagues for Dr. Hamid Kazarouni's talk. It'll be an excellent talk. Thank you.